Heart failure is when the heart can't supply enough blood to meet the body's demands. A variety of heart diseases like ischemia and valvular disease can impair the heart's ability to pump out blood, and over time can lead to heart failure. This can happen in two ways. Either the heart's ventricles can't pump blood hard enough during systole, called systolic heart failure, or not enough blood fills into the ventricles during diastole, called diastolic heart failure. In both cases, blood backs up, causing congestion or fluid buildup, which is why it's also often called congestive heart failure. Alright, so the heart needs to squeeze out a certain volume of blood each minute, called cardiac output, which is the heart rate, or the number of beats in a minute, multiplied by the stroke volume, or the volume of blood squeezed out with each heartbeat. Then the ejection fraction is the portion of blood that's pumped out of the left ventricle. In other words, the stroke volume divided by the total left ventricular volume. The ejection fraction is normally around 50 to 70%. Between 40 to 50% is borderline, and anything below 40% is systolic heart failure or heart failure with reduced ejection fraction. There's also diastolic heart failure, or heart failure with preserved ejection fraction. That's where the heart has very thick ventricular walls, so that the chamber doesn't get an adequate load of blood. So the heart's squeezing hard enough, but not filling up enough. In this case, the stroke volume is low, but the ejection fraction's normal. Alright, so heart failure can affect the right ventricle, the left ventricle, or both ventricles. So biventricular heart failure, which defines where the failure is happening. And then there's systolic or diastolic failure, which defines why the failure is happening. With left ventricular or left-sided heart failure, blood gets backed up into the lungs, and that causes pulmonary hypertension and pulmonary edema. Because of differences in diffusion rates, all the extra fluid makes oxygenation harder, but ventilation of carbon dioxide still works pretty well. Patients often have dyspnea, as well as orthopnea, or difficulty breathing when lying down flat. That's because lying flat allows more venous blood to flow back to the heart and into the pulmonary circulation, which worsens the congestion. All this extra fluid in the lungs causes crackles, or rales, on auscultation. A sign of severe left ventricular systolic failure is pulsus alternans, which is when there's alternating strong and weak peripheral pulses. This happens because the ejection fraction is significantly decreased, which in turn causes a reduction in stroke volume, so more blood remains in the ventricle. As a result, during the next systole, the myocardial muscle will be stretched more than usual, leading to an increase in myocardial contraction and a stronger systolic pulse. Now, with right ventricular or right-sided heart failure, blood gets backed up in the body. That can cause jugular venous distension, which can be seen with the patient sitting at 45 degrees as the jugular vein having a fluid wave that represents the filling level. Normally, it should be less than 3 centimeters vertical height above the sternal angle, but in heart failure, it goes higher than that. Blood can also back up into the liver and the spleen, and both can get enlarged. Excess fluid can also move into the interstitial spaces near the surface of the liver and the spleen, and collect in the peritoneum, causing ascites. Finally, fluid that backs up into the interstitial spaces within soft tissues in the legs causes pitting edema. That's where applying pressure with a finger leaves a pit in the tissues for a few moments. This mostly affects the legs, because gravity causes most of the fluid to pool there. Now, since the ventricles work in series, left-sided heart failure can also cause right-sided heart failure. And more rarely, right-sided heart failure will cause left-sided heart failure as well, since the backing up of blood in the venous system will affect the arterial system over time. So patients often develop signs of both right and left-sided heart failure. Now, if the ventricles are stiffened or dilated, eventually the atria will also undergo remodeling to adapt to the higher filling pressures. For this reason, in heart failure, there's often a third heart sound, or S3, heard on auscultation, which happens after S1 and S2. Finally, in advanced heart failure, there's decreased tissue perfusion leading to a resting sinus tachycardia, as well as cool, pale, sometimes cyanotic extremities, and diaphoresis, or excessive sweating due to hypotension, as well as narrow pulse pressure due to the drop in ventricular stroke volume. On a chest x-ray, there might be changes like pulmonary edema or cardiomegaly, but there are no specific signs that point directly to heart failure. On an ECG, there might be clues about the underlying cause of heart failure, like an arrhythmia or evidence of coronary artery disease. In a patient with any type of congestive heart failure, the key lab value is the brain natriuretic peptide, or BNP. A BNP level above 400 picograms per milliliter is typical in heart failure. Between 100 and 400 is borderline, so further testing needs to be done, and below 100 is unlikely to be heart failure. BNP levels can also be used to monitor a response to treatment as well. Echocardiography is then done to confirm the diagnosis of heart failure. It can estimate the ejection fraction, as well as measure ventricular wall and chamber size, which helps distinguish systolic versus diastolic heart failure. It can also assess the heart valves and estimate the pulmonary arterial pressure, to help identify causes and effects of the heart failure. Finally, a cardiac catheterization is the insertion of a catheter into a chamber, valve, or vessel of the heart. This can be done to measure the pressure in the chambers, study valvular function, and can be used to inject contrast media into the ventricles to perform ventriculography, which measures the ejection fraction. In addition, a coronary angiogram can be done to assess the coronary circulation to look for evidence of myocardial ischemia. After diagnosing heart failure, it should be classified. A widely used classification schema is from the New York Heart Association and is adopted by the European Society of Cardiology. There are 4 classes. Class 1 patients experience symptoms like dyspnea only after extreme exertion. Class 2 patients get symptoms from moderate exertion. Class 3 patients get symptoms from mild exertion. And Class 4 patients get symptoms at rest. In terms of treatment, right-sided heart failure is treated similarly to left-sided heart failure, especially because it's often a result of left-sided heart failure. Long-term management of heart failure includes management of underlying associated conditions, as well as lifestyle modifications, medications, and in some cases, using a device. Associated conditions include hypertension, ischemic heart disease, valvular heart disease, diabetes, thyroid dysfunction, and rheumatic fever. Lifestyle modifications include not smoking, not drinking alcohol, reducing sodium intake, and maintaining a healthy weight. The goals of medications are to improve symptoms, slow or reverse deterioration in myocardial function, and reduce mortality. Medications are given according to the New York Heart Association class. All classes must reduce sodium intake to less than 2 grams per day, and fluid intake to less than 2 liters per day. This helps reduce blood volume and pressure, which in turn reduces the heart strain. Additionally, all classes get a beta blocker and either an ACE inhibitor or an angiotensin receptor blocker, or ARB, if a patient develops a chronic cough from the ACE inhibitor. With each increase in class, we add another medication to the treatment. Class 2 patients also get either a loop diuretic like furosemide or a thiazide diuretic like hydrochlorothiazide to further reduce the fluid overload and relieve congestive symptoms. Class 3 patients also get aldosterone antagonists like spironolactone, or a combination of isosorbide dinitrate and hydralazine as vasodilators, to lower the blood pressure. Finally, Class 4 patients also get inotropes like digoxin, which increase the strength of heart muscle contractions, and should get a heart transplant if possible. All of these drugs need to be titrated, which means that treatment starts with a very low dose, and then increases progressively up to the highest tolerable level. If the patient has ischemic heart failure, aspirin and statins should be added to the therapy, regardless of the New York Heart Association class. In patients with a left ventricular ejection fraction below 35%, or in those with recurrent ventricular tachycardia or malignant arrhythmias, an automatic implantable cardioverter defibrillator, or AICD, should be used to reduce the risk of severe life-threatening arrhythmias and sudden cardiac death. In these patients, if the ECG reveals a QRS complex that's longer than 120 milliseconds, the patient should have a cardiac resynchronization therapy, or CRT pacemaker. CRT pacemakers can stimulate the ventricles to contract at the same time and improve the cardiac output. But if the QRS complex is shorter than 120 milliseconds, then the CRT pacemaker is optional, and medications like digoxin can be used to improve contractility. Alternatively, a combination of arterial and venous vasodilator medications, like nitroprusside and nitroglycerin, respectively, can be used to help reduce the systemic and pulmonary pressure, in turn reducing the heart's strain. If all other measures have failed, a final option is heart transplantation, or implantation of a left ventricular assist device, or LVAD, which takes blood from the left ventricle and pumps it through the aorta. An LVAD can offer temporary relief for patients waiting for a heart transplant, or be a permanent solution for others. Then there's also acute decompensated heart failure, which is when congestive heart failure rapidly worsens, resulting in the need for urgent therapy. If oxygen saturation falls below 90%, the patient might get supplemental oxygen, and below 80% they might get assisted ventilation. These patients might have such a reduced cardiac output that they can't adequately perfuse the kidneys, causing the kidneys to retain water, which worsens the volume overload and pulmonary congestion. So the goal is to rapidly reduce volume overload and reduce the pulmonary congestion. To do this, initial therapy includes intravenous loop diuretics. Also, intravenous vasodilator therapy can be helpful in patients with increased systemic vascular resistance due to severe hypertension, acute mitral regurgitation, or acute aortic regurgitation. These patients should be continually monitored in terms of their vital signs, volume status and daily weight, electrolytes, and symptoms of pulmonary congestion. In patients with reduced ejection fraction that show severe hypotension and end organ dysfunction, intravenous inotropic agents like dobutamine can be used. However, inotropes are not indicated for treatment of acute decompensated heart failure in patients with preserved ejection fraction. Finally, for patients with ejection fraction lower than 25% and severe hemodynamic compromise, mechanical cardiac support with either a ventricular assist device or an artificial heart can be used. The ventricular assist device helps the failing heart pump more efficiently, while the artificial heart replaces it. Alright, as a quick recap, right-sided heart failure typically causes jugular venous distension, as well as hepatosplenomegaly, ascites, and pitting edema on the legs. Left-sided heart failure typically causes dyspnea or orthopnea. A BNP serum level is usually over 400, and echocardiography can estimate the ejection fraction and assess the heart valves. The New York Heart Association groups heart failure into 4 classes, depending on severity of symptoms. Treatment of heart failure includes management of associated conditions and lifestyle modifications like not smoking, not drinking alcohol, reducing sodium intake, and maintaining a healthy weight. Additionally, drug therapy is given according to the New York Heart Association class. Class 1 gets beta blockers and ACE inhibitors, or ARBs. Class 2 also gets diuretics. Class 3 also gets spironolactone, or a combination of isosorbide dinitrate and hydralazine. And Class 4 also gets inotropes. Patients with a left ventricular ejection fraction below 35%, or those with recurrent ventricular tachycardia or malignant arrhythmias can get device therapy. If all other measures fail, a final option is heart transplantation.